Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Insulin.
Hey, Sam. It's nice to meet you. Do you have any concerns for me today?
Nah, I'm good.
I've been looking at your records. I see you've had diabetes now for about 15 years.
Yeah.
Your hemoglobin A1C is 7.4%. Looks like it came down a bit after you started insulin, but now it's rising again.
Yeah, it's still lower than it used to be. But it's probably as good as I can get it.
Are you taking your medications regularly?
Yeah, I'm taking them, but sometimes I forget though.
Sam, can I ask you,
Yeah, sure.
what is the hardest thing about having diabetes for you right now?
Honestly,
Yeah.
my mom, she had bad diabetes, kidney failure, hemodialysis 3 days a week. I think about it all the time. I just don't want to end up like her with no real life.
Yeah, I get it. I understand how scary that must be. And I want to tell you that fear is real and it makes sense. So let me ask, what are the top two things you would really like to change about having diabetes besides better control? Because we all know how important that is.
I want to be able to eat more foods I like without worrying. And I would also want to feel like diabetes is not controlling my entire life.
Those are really important goals. And I have a suggestion that has helped many people with similar desires. I'd like to suggest that you start a continuous glucose monitor or a CGM.
I've seen those. I don't know if I want to be bothered with all that. I mean, having to wear something all the time. I mean, can we just wait a few more months? I'll make the changes to get better.
Well, your A1C is still above target, even with the insulin. So I hear you saying that you are really going to change, and I absolutely believe you want to. But wouldn't it be nice if something could monitor your blood sugars and give you a break from thinking or worrying about your diabetes?
I guess that would be nice. Yeah.
I would really like to help you achieve better control and reach your goals. A lot of people have told me that they don't work harder with CGM, but they actually work less. The CGM does the monitoring and the reminding for you.
Can I figure it out?
Yes, absolutely. My team and I will make sure you understand everything and you get the apps and the alerts all set up. You can use your phone if you want to, but also you don't have to.
I guess I can give it a try.
Okay,
Yeah.
we'll try it. If you don't like it, when you come back, we don't have to continue. Fair enough?
Yeah, I'm just so busy with my new work schedule. I don't think I can come back in for a while.
No problem. We'll get a telehealth appointment set up instead. Sound good?
Well, that would save me the drive. Okay, let's do it.
Let's do it.
Hello, I'm Dr. Eden Miller. I'm a family medicine specialist, diabetologist, and obesity at my clinic in Bend, Oregon, diabetes and obesity care. This clinical encounter is what we do every day. Trying to really take individuals who are struggling with their A1C. An A1C of 8.3 is currently the national average. So, this individual is no different than what we see on a day to day basis. But what we're trying to do is turn our patients into experts on their own disease. And we're trying to give them the tools that will empower them to learn more about their own individual journey in diabetes. One of the number one things that I have learned when I worked with the ADI and overcoming clinical inertia, when we did a survey looking at individuals with their barriers, they were fearful of the complications related to type 2 diabetes. They really were. They had other conditions that competed for their attention. They had a hard time engaging in lifestyle, and they really kind of didn't feel like they had a real good partnership with their healthcare team. CGM is the standard of care for any person on insulin. I don't care what flavor of diabetes you have, and it is highly covered by all insurances, including Medicare and Medicaid. In fact, the standards of care just came out with the 2026 guidelines, and they're even stronger with utilizing technology. So, if you can empower your patients with a CGM, especially when they're using basal insulin, you can give them that tool, what I call patient driven titration, where they target a blood sugar in the morning, they add an additional unit every day that they're not at target, or they can pull away a unit if they are below target to prevent hypoglycemia. I love having patients use the data not as a shame and blame, but as an empowering tool. They can find the Fab Five, right? Those five foods that individually for them don't affect their blood sugar, but also those forbidden five, because not all foods affect a blood sugar in a negative standpoint. And so imagine empowering that patient to find the foods that really do well with them and the ones that they want to avoid. And, especially understand that we can do all of this remotely. We can give Sam the power to monitor blood sugars, and then we don't even have to have him come into the office because this technology can be downloaded, it can be transmitted, that data. We can monitor, we can look for flags. And then the next appointment to make sure that it's a short interval. I say 2 to 4 weeks so we can go through that data and I can ask Sam, what does he learn? What did he figure out? I even share that AGP report with them through secure email so we can have it a very purposeful appointment. So let's see how that tele appointment follow up ended up unfolding.
Hey, Sam, good to see you. Can't wait to hear. Tell me, how are things going with the CGM?
Oh man, you're not gonna believe this. I went to the barbershop last week and one of the guys saw it. And then everyone in there started asking about it. What's it do? Do you like it? Does it hurt? And I'm telling them, yeah, it's working pretty good. And I can eat more foods I like now. I actually told one of my buddies with diabetes to ask his doctor about it.
Look at you leading the way. I love it. And now I know you must be doing well. Did you see the AGP report the nurse emailed you yesterday?
Yeah, I looked at it.
First of all, nice job. Your A1C is 7.1%.
Yeah, I'm getting closer to my goal.
Was wonderful. So tell me, what have you learned these past few weeks?
Well, I adjusted my insulin, like you said. I'm up to 46 units now.
Nice job. It's really good work.
I noticed that my sugars are high a lot after I eat,
Mm.
but I'm still trying to figure out what foods cause it. I definitely know that pasta is a big one, and orange juice. Wow, that really shoots me up.
Okay, well, that's a good start. Let's keep working on it. Usually takes a little time to get a really good list going. So tell me, what do you think the next step is for those post-meal spikes?
Um, I don't know. I mean, I still feel like diabetes is dictating what I eat,
Mm.
even though I'm trying to do better.
Okay, it sounds to me like you may need mealtime insulin.
Yep, but that's more shots.
Okay, hear me out on this. You hung with me on the CGM technology and it's really helped, right?
Yeah, so far.
So what if we try one step further with an insulin pump? Now, what if I told you the insulin you're taking at night can be put in a pump, which takes away the injection, and the pump can work with the CGM to automatically do both the monitoring and the dosing for you?
I don't know. I mean, it sounds like a lot. What if something goes wrong with it? Like, what if it doesn't give me enough insulin?
Good question. So we can adjust the pump settings, and it also has built-in safety features with some really good safety evidence. We would also, of course, make sure you have backup insulin supplies on hand, and we teach you how to handle any issues.
Okay, but will people be able to see it?
There are so many different kinds of pumps available now. Should we go over them and decide together which one is best for you?
I don't know.
Dan, you have come so far in just 4 weeks, but there's still work to do.
I know. And I really don't want to add more shots.
Okay, I'm going to remind you how you told me at our first visit together that you were afraid of complications and you didn't want diabetes to dictate your life.
Yeah.
So if we go to a pump, that's another step toward achieving more control without having to work any harder.
Yeah, I guess so. I have a new grandbaby now, and I want to be there for him. So, what do we need to do if I get a pump?
Well, we'd go over the different pumps together and order the one that you choose. Then I'd set you up an appointment with a pump trainer. So let's look at calendars.
What a fun conversation to have with Sam. I love how he brought his community in with the barbershop talk. I can see that he is being empowered of all the different glucose places he goes by utilizing technology, utilizing CGM to see his personal journey. One of the nice things about starting with CGM is really illuminating to persons kind of what happens in real time with their diabetes. And, a lot of times I can have a better conversation regarding insulin. One of the largest therapeutic inertias in medicine and type 2 diabetes is the time to the addition of insulin, but also the time to titration of insulin. And really, the biggest chasm in advancing care, or what we call inertia in type 2 diabetes management, is adding mealtime insulin. And, one of the things that I think is going to be the new direction for kind of reinventing insulin administration in type 2 diabetes is having pump conversations. I know many of you listening are thinking, pump, I never thought about that for a person with type 2 diabetes. Oh, there should be so many barriers. No, there actually aren't. Pumps are now being approved and encouraged for type 2 diabetes. In fact, the new standards of care of 2026 says a type 2 person on insulin should be recommended an AID insulin pump type of consideration. The Secure T2D trial really illuminated a lot about how that improvement and quality of life can be there. One of the nice things about that particular pump is it's at the point of care, a pharmacy. That makes it a lot easier. You can also kind of buy it before you try it, kind of thing, where there isn't a warranty. Some of the other pumps that are out there that are more hardware, kind of external pumps, you need to have a kind of a warranty regarding it. There is emerging data for all three of the pumps, by the way. So I want you to understand that they have indications and emerging data. There's quite a bit of real world data coming out, and there's a lot of myths associated with type 2 and pumping. First of all, is like cartridge or pod size. We see about a 30 to sometimes 40% reduction in total daily insulin when you're going from either basal or basal MDI, multiple daily injections, to AID insulin infusion pumps. So a lot of my colleagues think that if you're at a high level of utilization of insulin, you're not going to be a pump candidate. Not the case at all. We also see a lot of barriers related to, well, my patient can't figure it out. No, it's at a fifth grade level, and you just have to get them the proper training. And so it's important to match the technology to the person, to have a rudimentary knowledge of the different technology out there, to ask the person, what would you like to gain from a pump? Because you can gain that freedom, that constant monitoring and mitigation of glucose is where the patient doesn't want to think about their diabetes all the time. I always say an AID remembers you have diabetes when you don't want to. It's important to create a workflow, understand you as a clinician. Even if you don't want to actually do pumps, be the facilitator, don't be the barrier. Make sure that you know where to go to identify either CDCESs or other people in the community. If it's something you want to do, by all means, you're getting some of the knowledge right now. Make sure you're referring to a certified pump trainer or PharmD, and get that follow up 2 to 3 weeks later. So then you can go over with our patient Sam how he's doing, how the settings need to be changed, how to adjust them. Don't think you have to do this in one appointment. This is a journey. It's a bit of a marathon. on. And what you're going to do is start getting this patient comfortable and engaged with their diabetes using AID. So I'm looking forward to our follow up visit with Sam and see how he's doing incorporating new technology into his care.
Wow, look at this. Your A1C is 6.8%. 6.8% is less than 7, which is exactly what we want to see. And your total daily insulin dose is actually lower now.
Can't believe it. I can eat more of what I want. Like if I want to go out for dinner, I can actually do it if I've been doing good in general. And honestly, I've been doing better with my diet because I'm not feeling so restricted all the time.
Well, that is what we were hoping for. How's the carb counting going? I know the pump trainer went over that with you.
Yeah, well, I've tried, I mean, but it feels like a lot.
Yeah.
To be honest, I usually just put carbs in for dinner, but breakfast and lunch, I mean, I don't know. I mean, counting everything all the time just feels overwhelming. And I don't always have a label.
I totally understand. You know what? I'm going to let you in on a little secret.
Okay.
So, the pump trainer did great teaching you the full system, but we can simplify this. Okay, you do not have to do precise carb counting. You can do fixed carb amounts instead if you want to try that.
What do you mean?
Well, if you're eating a similar breakfast every day, you just put in the same number each time, like 45 grams, 45 grams, 45 grams. Or you could even do small, medium, and large meals, like 30, 45, 60 grams.
Oh,
Yeah,
I like that. Small, medium, large.
right?
I mean, that's seems a lot easier than trying to figure out if my oatmeal is 32 or 38 grams.
Yes.
So
Good.
like,
Do you want me to change those settings on your phone? I can just go ahead, put those digits right
oh
in.
yeah, sure.
Okay. We're gonna do small meal 30 grams, medium 45, and large 60. Sound good? No, we can always go back in and adjust these numbers later. And while I'm here, let's just take a look at your alarms as well. How's that going? Any issues? Too little? Too many?
Well, I like that it lets me know if my sugars are too high or too low, but it did wake me up a few times.
Okay, I can adjust the alarms a little bit here too.
Okay.
Okay, now we can schedule an appointment in a couple of months with these new settings.
Sounds good.
And Sam, call the office if you have any problems. Low or high blood sugars, anything like that, okay? But most importantly, I want you to really trust your pump. You don't have to talk to it much, but don't ignore it when it's trying to tell you something. Just tell it what you're eating, what your blood sugar is if it asks.
Got it. You know, when I first came to you,
Yeah,
I never thought I'd be sitting here talking about trusting a machine.
I know.
But I'm starting to feel like I'm getting a handle on diabetes now, you know?
That's great to hear. And that is the goal. And you have come a long way, Sam.
Thanks.
Good to see you. Say hi to that grandchild.
You know, in my experience in clinical practice, a job begun is half done. A lot of what we are doing is setting a foundation for future success. You know, one of the challenges of insulin administration and type 2 diabetes is they go through different insulin chapters. You know, when you have type 1 diabetes, you know, AID systems are standard of care, but yet type 1s get kind of thrown into the insulin pool. They either have to do it or they die. Whereas type 2, who kind of graduate through the different stages of insulin administration, it can seem a little daunting. But the needs of a person with type 2 diabetes with mealtime and basal control are the same. And so understand that there are some real world challenges, but you can be equipped to overcome those and identify them. You know, there is a lot of limited tools on how to kind of overcome these, but you know, it's just kind of really common sense. We talk about matching the technology to the person, and I always ask this question of any person with diabetes: What would be one of the things that you would like to be easier or kind of facilitate you in control? If it's whether they forget to take shots or they have trouble with mealtime or they feel like they have to take shots and feed the beast all the time, those are what you need to do top of line first, because that's what you want to do is match that challenge. Now, one of the things that there's this perception of pumping with type 2 diabetes or using AIDs is they have to be carb counting experts. Not at all. In fact, a lot of the data shows that you can actually, in a person with basal insulin who needs some additional control, you can actually start them on an AID. And then what's nice is when they do go to their first mealtime calculation, you don't have to carb count. You could do meal announcement of a fixed carb, like, every meal is 45, or you could do what we call small, medium, and large, where you have that discussion with the pump trainer or you as a clinician. You find out what a typical small meal is, like 30 or 45 or 60 grams of carb. There are often applications such as custom food and meals in many of these AID systems that you can have conversations with the patients so they're already programmed in. Make sure that the alarms facilitate their attention, not be something that is burdensome, but be familiar with how the settings or the algorithms of each pump can actually strengthen their control. And one concern that I get from a lot of my colleagues is hypoglycemia. I think that's where AID systems shine. Many of the inertia related to type 2 diabetes is insulin, how should we say, aggressiveness, because we're afraid of hypoglycemia. One of the amazing things about AID is how protective they are on hypoglycemia. And there are ways to encourage the patient of how to engage and to do different settings that's going to really help prevent that. Now, what's imperative to be successful in incorporating technology in your clinical practice is to understand that you have many team members. In your own practice, you may have several team members. You may have to go outside of your practice to find that. Make sure you have somebody who's a diabetes champion, who understands you want to incorporate technology, has a knowledge of the technology. Make sure that you have a pump trainer, whether they're in your building or outside your building. And there are so many resources online for you to utilize. Don't forget to monitor. Many of our technology goes unmonitored. You don't know how many CGMs are not downloaded. And understand that this data is for you to have direction for the patient. So, I want to give you some food for thought. We need to up our game when it comes to management of type 2 diabetes and insulin. Technology is launching us. It's putting all persons on an equal footing. It's filling in the gap. It's leveling the playing field. I urge you to get to know technology, to open your clinical practice to utilizing technology in type 2 diabetes. I think you're going to find it's a time saver and you're going to get patient buy-in, increase engagement, and great results. Thank you so much for listening.